Dr. Apter, I'm sure you have a very short question.
Sure. Can you compare and contrast for us, Glenn, the data of the PCV versus what we know about the non-PCV patients? And then, since you have brolucizumab on the shelf now, are you going to switch all your patients to?
So another two questions. So the first one is to compare the patients who have PCV, the results for PCV, to the results for the patients who don't have PCV. And I would say to start with, the results that I showed you were the sub-study of the larger group, and this is not so this is a comparison of PCV to everybody as a whole. It's not directly comparing those who have PCV to those who don't have PCV in the Japanese population. That's a analysis that's being done as we speak. But in general, the results for the patients with PCV, if anything, were slightly better than the patients as a whole. So they were robust visual acuity gains in this group. And then the question is, based on this, do I switch all my patients over to brolucizumab? And so what I would say to start out with is that for patients who have polypoidal, I feel very comfortable using monotherapy to start with. One of the questions is, should you combine that with PDT or other adjuvants? And at least for this study, it seems that starting with monotherapy is worthwhile. And one of the things that I think is notable, just to bring it out again, is that you can identify the patients who can go to every 12-week dosing very early on. It was after the first time that they made it past that disease activity endpoint that you could tell that they were very highly likely to be able to stay at that dose. So I think it's a very good potential choice. Now, whether I'm going to use this versus aflibercept versus Eylea versus ranibizumab, I don't have all the data for PCV, so my best data are for brolucizumab. Aflibercept also is reasonable for monotherapy. We saw a little more drying in the brolucizumab group, and how that translates to better visual function, not just visual acuity, visual outcome, or visual function, we don't really know. And a lot of these decisions, as you know, are going to be based on the payer, the patient's ability to pay for the drug, et cetera, et cetera. And so there's going to be a lot of individualized treatment also.
So Glenn, you made a comment that basically if you could identify these people, have you tried to go backward and identify the people who basically didn't make it for the 12-week interval?
So I think I heard the question as, have we gone back to see what happened to the people who didn't make it to the 12 weeks, and then why did they not make it to the 12 weeks? I don't have the detailed analysis of those patients yet. Okay, thank you very much.